this class we will be discussing on the drugs used in COPD, Chronic Obstructive Pulmonary Disease, Rhinitis and cough. Tell me the drugs used in bronchial asthma. Anyone? Drugs that are used in bronchial asthma. What are the drugs that can be used in bronchial asthma? Anyone? Any one drug? Drugs that are used in bronchial asthma. সাবা বললে হবে না, it should be short acting beta 2 agonist, তাই তো? হ্যাঁ, bronchodilator is a broad term that contains short acting beta 2 agonist, long acting beta 2 agonist, and then আর কি আসে ওতে? Anticholinergics রয়েছে. Can you give me some example of short acting beta 2 agonist? Anyone? Others? Salbutamol. আর কি আছে? Tiotropium. Very good. Long acting beta 2 agonist নাম কি হবে? হ্যাঁ, Benbuterol or Salmeterol, Formoterol and others. Anticholinergics, huh? Irreversible. Okay. Irreversible is short acting or long acting? Short acting. Long acting नाम जानो? कि Tiotropium. Good. Methylxanthines কি আছে? Sorry? Theophylline. हाँ. अच्छा, स्टेटस एस्थमेटिकस এর ট্রিটমেন্টটা কি আছে? Status asthmaticus is a medical emergency. How we will treat those patients? It's a common classic question in the exam. এর করতে হবে, হ্যাঁ? Now coming to the COPD, Chronic Obstructive Pulmonary Disease. The primary pathophysiology in bronchial asthma was reversible airway obstruction due to inflammation, but COPD is an irreversible airway obstruction, unlike asthma. As it is irreversible, the treatment does not alter the pathophysiology of the disease, but what we do, we aim to treat the symptom of the patient so that the patient quality of life will be better. So, it is irreversible airway obstruction. The drug relieves only symptom without treating the underlying pathophysiology. Aim of the treatment is to lessen the airway obstruction so that the breathing symptom will be decreased, and to improve the quality of life and to treat secondary complications. What can be the secondary complications in COPD? It can be hypoxemia, hypercarbia, infection, cor pulmonale. Cor pulmonale mane? Cor pulmonale is basically the failure of the right side of the heart due to long lasting respiratory disease. Now coming to the treatment options for COPD, limited very much. Number one, to stop smoking. Smoking is one of the very important risk factor for COPD. To stop smoking, we can give some vaccinations, influenza and pneumococcal vaccination. Basically, they help to reduce the severity of infection if the COPD patient contract it. So, influenza and pneumococcal vaccination, proper judicious use of antibiotics, because in many COPD exacerbations, basically they can be non-infective. So, proper judicious antibiotic therapy in respiratory tract infections. Now, what is the drug of choice? In patients of COPD, long-acting muscarinic antagonists are the drug of choice. Drug of choice in basically bronchial asthma. Drug of choice in bronchial asthma, beta 2 agonist. Now, in case of COPD patients, basically long-acting muscarinic antagonists are the drug of choice. Why? Because the cholinergic tone in COPD patients are higher. Unlike asthma, where long-acting beta 2 agonists are the most effective. Current guidelines recommend use of long-acting muscarinic antagonist with long-acting beta 2 agonist in patients of COPD. Now, what the difference with the asthma? In asthma, basically we combine beta 2 agonists with corticosteroids, inhalational corticosteroids. The difference with COPD, in COPD we combine long acting muscarinic antagonists with long acting beta 2 agonist. ICS is not preferred. And add-on therapy with inhalational corticosteroids in very severe case, as well as short acting beta 2 agonists as and when required. Theophylline can be added orally. Revifenacin is a newer long acting muscarinic antagonist that has got sustained long acting bronchodilator action with minimal anticholinergic side effect. Now, systemic corticosteroids generally avoided, no role except in case of severe exacerbation to reduce the hospital stay. It should be given for a brief period in some patients. In patients with long standing hypoxemia, domiciliary oxygen therapy can be given. Use of mucolytics and expectorant are controversial. Well, now coming to the second topic, rhinitis. Rhinitis basically we define as the presence of one or more of the following symptoms. What are they? Number 1, nasal congestion, rhinorrhea, sneezing, itching. Presence of any one of the four basically defines rhinitis. Rhinitis can be allergic rhinitis, can be non-allergic rhinitis. Coming to the non-allergic rhinitis, it can be associated with inflammation like in any infection, and in non-allergic rhinitis eosinophilia syndrome, it may not be associated with inflammation like in case of vasomotor rhinitis or atopic rhinitis. Now, how we treat allergic rhinitis? The mainstay of therapy is avoidance of allergen. Then oral antihistaminics are the drug of choice, and second generation antihistaminics are more effective here than first generation antihistaminic. If we can use intranasal corticosteroids as an alternative therapy to oral antihistaminics, or where oral antihistaminics are not effective. Combined use of intranasal antihistaminic and intranasal corticosteroids in resistant cases. And leukotriene receptor antagonists can be given in patients with allergic rhinitis with bronchial asthma. And if patient is non-tolerant to any of the therapy or or in case of refractory allergic rhinitis, allergen immunotherapy is given. Oral antihistaminics, second generation antihistaminics are superior. First line therapy for mild to moderate allergic rhinitis. Combination with intranasal corticosteroids can be used for moderate to severe allergic rhinitis or refractory symptom. Coming to intranasal corticosteroids, they include fluticasone, mometasone, budesonide. Now, they are effective in mild, moderate or severe allergic rhinitis, any of the thing. First line therapy in allergic rhinitis or can be used as an alternative to oral antihistaminics. Intranasal corticosteroids can be combined with intranasal antihistaminics in resistant cases. Now, systemic corticosteroids generally not indicated as risk is outweighing the benefit. So, it can be used in severe allergic rhinitis with comorbid bronchial asthma or nasal polyposis. Oral and intranasal decongestants, they include alpha agonists like oxymetazoline, phenylephrine, pseudoephedrine. Now, both oral and intranasal formulations are effective in running nose, but oral therapy causes more side effects. Short term use of it can be used for short term in severe allergic rhinitis, but it should not be used for more than a week. That can lead to basically rhinitis medicamentosa, that is atrophy of the nasal mucosa. They are contraindicated in patients with heart disease, in hypertension, in benign prostatic hypertrophy, thyroid disease and diabetes. Now, leukotriene receptor antagonist, Montelukast is the widely studied drug here. It can be used in moderate to severe allergic rhinitis lesser effective than intranasal corticosteroid. They can be used as an add-on therapy and in patients with AR with bronchial asthma or to treat nighttime symptoms. Biologics. The most widely studied biologic here is omalizumab, that is IgE receptor antagonist. They are used to control uncontrolled allergic rhinitis and allergic bronchial asthma, but cost basically limits the use of the drug. Immunotherapy, both subcutaneous and sublingual preparations can be used. Sublingual preparations are more safer than the subcutaneous preparation. During the onset of the therapy, যখন থেরাপিটা আরম্ভ করা হয়, there should be rescue medications in hand, and due to their adverse effect, the use of immunotherapy is only recommended in the secondary care setting. Coming to intranasal sodium chromoglycate, they can be used in pregnant mother safely. Intranasal anticholinergic Tiotropium bromide is used. Rapid onset of action, frequent administration due to short half-life. They only treat watery nose, running nose, and they have got action or no other action on any other symptom of rhinitis like itching and others. Special precaution for use in benign hyperplasia of prostate and in narrow angle glaucoma because of anticholinergic side effect. Non-allergic rhinitis, we should avoid the irritant. Number one, nasal irrigation can be done by saline rinse or spray. They thin out the nasal secretion. Intranasal corticosteroids reduce inflammation. Antihistaminic spray reduce sneezing, itching, congestion. Anticholinergic spray, they basically reduce the tenacity of the nasal secretion. Oral medication, they help with congestion, decongestant. Oral antihistaminics are generally less effective in non-allergic rhinitis than allergic rhinitis. Now coming to the cough. Cough is a protective reflex that basically help in removing the respiratory tract secretion unwanted and to remove the foreign bodies. Now they are caused due to stimulation of mechanoreceptors and the chemoreceptors in the respiratory tract. They can be caused by infection, inflammation, bronchogenic carcinoma, smoking, cigarette smoking. Some drugs can cause cough. What are the drugs that can cause cough? Cardiovascular system hoise. So ACE inhibitors, these are one of the drugs that can cause cough. Acetylcysteine can cause cough. Amiodarone, any inhaled medication, and iodine. Now what are the types of cough? Cough can be protective or productive cough and can be dry cough. Productive cough, basically they help out to bring out the respiratory secretion, unwanted respiratory secretion. So they are useful. But dry cough, they basically are useless and it should be controlled. It should be basically suppressed if it is distressing to the patient or if the patient condition demands, like in patients with heart disease or after surgery. Now what are the drugs that can be used to treat cough? We divide them into two groups. Number one is antitussives. What does antitussive mean? They basically suppress the cough and they can be centrally acting via their action on the cough center, or they can be peripheral acting, where they decrease the sensation of the pulmonary stress receptor, or it can be expectorants, or also called mucokinetics. Expectoration, either they increase the respiratory secretion or they thin out the thick mucus plugs. The drug who increase the respiratory secretion, they are called secretion enhancers, and the drug which thin out the mucus plugs are called mucolytics. Now coming to the centrally acting antitussives, it can be opioid drugs, it can be non-opioid. Opioid drug includes codeine, folcodeine, ethyl morphine. Non-opioid include noscapine, dextromethorphan, clofedienol, prenoxdiazine. Coming to peripheral acting, it includes benzonatate. Benzonatate has got both central and peripheral action. Pharyngeal demulcent, basically they soothe out the pharyngeal mucosa. Steam inhalation and bronchodilator like salbutamol, terbutaline. Secretion enhancers, they include guaifenesin, potassium citrate, potassium iodide, ammonium chloride and Vasaka. Mucolytic, they include bromhexine, they include ambroxol and then carbocystine, acetylcysteine. US FDA has approved only guaifenesin among the expectorant. Coming to the antitussive, as they suppress the cough, they may be centrally acting, they may be peripherally acting. Now, among the centrally acting antitussive, it can be opioid. So, morphine and its congeners are effective antitussives, but morphine is not preferred. Why? Because of strong addicting liability, number one. Number two, respiratory depression side effect. Codeine. Codeine is more selective for the cough center. It has got lesser addiction liability or respiratory depression effect compared to that of morphine. But the major drawback is constipation. Constipation is a major side effect for codeine. Respiratory depression and drowsiness can occur at higher dose. They are contraindicated in asthmatic patients. They can cause bronchospasm and in patients with decreased respiratory reserve. Ethyl morphine similar to that of codeine but less constipating, and fall codeine, they are longer acting with no analgesic or addiction property. Coming to non-opioid antitussives, they include noscapine, they suppress cough, no narcotic, analgesic or dependence inducing properties, headache, nausea, occasional, can release histamine and can cause bronchospasm. Dextromethorphan, they act centrally in the NMDA receptor. They are basically synthetic central NMDA receptor antagonists. They do not depress the mucociliary clearance. They does not cause constipation, although it is non-addicting, but some person can indulge with dextromethorphan. Dizziness, nausea, drowsiness, hallucination, ataxia at the higher dose. Clofedienol is a centrally acting antitussive with weaker anticholinergic, antihistaminic and local anesthetic property. Prenoxdiazine, developed in Hungary, desensitized pulmonary stress receptor, efficacy not that compared to other drugs. Pharyngeal demulcent, they soothe out the pharyngeal mucosa. They are effective in cough originating above the larynx, and they include lozenges, syrups, glycerin, licorice, may be used as and when required. Benzonatate is both centrally and peripherally acting. Centrally, they basically inhibit the afferent cough impulse, and peripherally they inhibit pulmonary stress receptor. As they are structurally related to anesthetic tetracaine, they have got also mild anesthetic action. Steam inhalation, no cost, much effective. So, is the safest and economical method of treatment. What does steam do? Steam basically thin out the mucus, the respiratory secretion. They are highly useful in bronchiectasis. They are effective in cough originating below the larynx, and often some aromatic substance like tincture benzoin, they are added to the hot water or the steam, but the action is basically more placebo. Steam inhalation is the most economical and devoid of any side effect and can be considered as the best expectorant mucolytic cough suppressant. Bronchodilators, they are effective in cough caused by bronchospasm, like in patients of bronchial asthma, asthmatic bronchitis, eosinophilic bronchitis. Antihistaminics, first generation antihistaminic can be used like dimenhydrinate, diphenhydramine. The problem is that they cause sedation, and how does they act? They basically suppress the cough center in the brain. Sedative effect not desirable, they dry up bronchial secretion. Local anesthetics, lignocaine is used. It can be used as a nebulizer therapy in patients with bronchogenic carcinoma. Number 1, it can be used as basically they coat the instrument like endoscopies to prevent the cough, and number 3, they can be used as lozenges in intractable cough. Hydration, basically maintaining hydration can thin out the respiratory secretion. So, we always suggest a patient having tenacious sputum to drink plenty of water. Now, coming to expectorant, they can either increase the respiratory secretion or make the respiratory secretion more basically liquid. Coming to secretion enhancers, they can be sodium and potassium chloride. They increase the respiratory secretion by salt action. Potassium iodide, problem is they affect the thyroid function and can cause iodism. Guaifenesin, Vasaka, Tolubalsam, they increase bronchial secretion and increase the mucociliary clearance. Ammonium salt, they are nauseating, they reflexly increase bronchial secretion. Bromhexine is a mucolytic. What does they cause? They depolymerize the mucopolysaccharide in the respiratory secretion and thus makes them less viscid. So, they are derived from alkaloid vasicine. Rhinorrhea, lacrimation, nausea are the side effects. They can breach the gastric irritation. Ambroxol is a metabolite of bromhexine and similar in pharmacokinetics and pharmacodynamics. Acetylcysteine. Acetylcysteine basically they break the disulfide bond in the mucus plugs and make them less viscid. Administered orally as well as by nebulization. Achha, use of acetylcysteine other than expectorant, paracetamol toxicity পড়েছো? Drug of choice কি? Acetylcysteine. Well, so it can be administered orally as well as by inhalation. Now, gastric mucus barrier may be breached by orally administered acetylcysteine, so they should not be used in peptic ulcer patient. Nausea, vomiting, stomatitis, bronchospasm. They are also useful in paracetamol toxicity, off-label use, dry eyes. Carbocysteine, similar in action to acetylcysteine, administered orally may break gastric mucosal barrier, so contraindicated in peptic ulcer patient. Now, coming to some MCQs, which of the following is the key characteristic of airway obstruction in bronchial asthma? The irreversible and progressive, reversible and triggered by allergen, always associated with smoking, fixed obstruction. Reversible and triggered by allergen, irreversible and progressive কার আছে? COPD patients. So, COPD basically they are irreversible airway obstruction. So, it is irreversible progressive for COPD, reversible and triggered by allergen is in bronchial asthma, always associated with smoking. Generally, smoking is an important risk factor for COPD. Now, which inflammatory cell is most predominantly involved in the pathogenesis of asthma? This bench? Eosinophil. Which of the following drugs should be avoided in asthmatic patient? Beta blocker. Beta blocker can cause bronchospasm. What is the mechanism of action of Montelukast? না, লিউকোট্রাইন রিসেপ্টর অ্যান্টাগনিস্ট। মাস্ট সেল স্টেবিলাইজার নাম কি আছে? ক্রোমোলিসোডিয়াম। Name some inhalational corticosteroid. Inhalational. Budesonide. Beclomethasone. A patient with acute asthma presents with difficulty speaking and respiratory rate 48 per minute. So, what is the diagnosis here? Very high respiratory rate, patient can't even talk. a known patient of asthma. So diagnosis, diagnosis কি আছে? A patient of asthma having difficulty in talking, respiratory rate 48 per minute. What can be a diagnosis? It's a medical emergency. The patient is suffering from status asthmaticus. Okay. Now, which of the following is considered a reliever medication? Reliever medication ki hobe? It should be beta 2 agonist, short acting beta 2 agonist. What are the options? Fluticasone, salbutamol, salmeterol, budesonide. So salbutamol is the drug of choice here. In a stable COPD patient, which class of drug is considered first line long term therapy? Long acting? Which bronchodilator? LAMA. Generally we combine long acting beta 2 agonist with long acting muscarinic antagonist. Inhalational corticosteroid, kothay drug of choice? Bronchial asthma, because of its anti-inflammatory action. Which medication is used to thin sputum in a patient with a productive cough? Thin sputum mane mucolytic. Now codeine is basically antitussive, centrally acting opioid. Ambroxol is basically mucolytic. Dextromethorphan, antitussive. Promethazine is an anticholinergic, antitussive action. Which of the following is not a typical side effect of high dose nebulized salbutamol? So beta 2 agonist side effect কি আছে? Beta 2 blocker কি করে? হার্ট রেটটা কমায়, তাই তো? তো beta 2 agonist কি করবে? হার্টবিটটা বাড়াবে। So it causes tachycardia. আর কি করতে পারে beta 2 agonist? Tremor, হাত কাঁপতে পারে, palpitation করতে পারে because of tachycardia. It can cause hypokalemia, beta 2 agonist. Hypokalemia করে. So bradycardia is answer. Bradycardia is not a typical side effect of high dose nebulized salbutamol.